Good evening, everybody. Today is Tuesday, August 3rd, 2021. Today we're going to be doing case list defense. I'm Zoe Million. Before we start, I'd like to make sure that everyone can hear me. Can you raise your hands if you can hear the audio? Okay, thank you so much. I appreciate it. Before we start, does anybody have any questions about anything? It could be in regards to your case list construction, anything in general about the exam. I see Tiffany has her hand up. I'm going to go to Tiffany here. Okay, your hand's down. Anybody have any questions about anything before we start? Okay, so who would like to be on the hot seat? The way today's webinar works is we have hopefully you submitted your case list, and then you get on the hot seat and you can pick a case, or it could be random, and as if you were on the exam defending the cases on your case list. So do I have anybody that's interested in being on the hot seat? If somebody did not submit their case list, we can use somebody else's case list. You could pick a specific list that you like to focus on, and we could just randomly pick a case. So is anybody interested in being on the hot seat? Don't be shy. Because I only have 4 case lists submitted. So anybody interested in being in the hot seat? Richie, I saw your hand up. It went back down. Are you interested in being the hot seat? Says you're self-muted.
Can you hear me
now? Yeah,
Yes.
we can hear you. Perfect. Awesome. All right. Let's go to your list here. Is there any particular, do you have any questions before we start about anything?
No questions.
No questions. Any particular case you're concerned about, or a particular list you want to focus on, and we can randomly pick? What are your thoughts?
We can do whatever list. We can do gyne if you want.
Now, you're a generalist,
No, I'm just a gynecologist.
so you focus on GYN. Are you like MIGS, Urogyne?
I'm MIGS. Yes, I'm MIGS.
So you feel comfortable with OB?
No way.
So let's go to OB, man. Let's work on that.
Well, I didn't even study any OB, so I feel like it would not be very
Really?
yield. Yeah.
Seriously? You should go for the sections that, you should know more than I do in regards to the GYN, I'm assuming. It's up to you. It's what you like. I'm going to kind of make this a little bit more zoomed if I can.
Sure.
I hope it makes it even shorter. There we go. Any particular case? But,
Nope.
I mean, it's not, and we're here among friends, as I say. I'm sure there's a tape of me messing it up in a webinar many, many moons ago. You want to mess up here. You don't want to mess up on the exam. You want to pass that exam.
Yeah.
So is there anything that you're interested in looking at?
No, I mean, whatever you feel I may get asked about, that would be the most useful.
Yeah, it's a big list. So let's look here. So case number 50.
Yes.
Can you explain to me how you enter the abdomen with your laparoscopic cases?
For my laparoscopic cases, I enter Hassan.
And why do you use this, Hassan?
I enter Hassan because I am more familiar and comfortable with that technique of entry.
And can you explain how you do the Hassan?
Sure. So I grasp the umbilicus with Alice clamps. I incise the umbilicus vertically to about 10 millimeters with a scalpel. I identify the fascia and grasp it with coker clamps. I then use a scalpel again to incise the fascia, and then I bluntly enter the peritoneum with mets and bombs. I confirm entry by visualization of bowel or omentum.
And roughly how long does the Hassan take you to enter the peritoneal cavity?
Takes me about 30 seconds.
That quick?
I do it very often. I haven't done varus in a long time.
And why don't you do the varus?
I don't do the varus because I don't do it often enough to feel comfortable.
And you say this patient had opioid dependence. Can you explain that for me?
This patient had opioid dependence in that she had chronic pelvic pain, and in order to manage that, she was seeing pain management and was managed on fentanyl patches and short-acting oral opioid medications.
For how long?
Several years.
Did she have a known diagnosis of endometriosis?
Per her previous operative reports, she had a laparoscopy shown endometriosis.
How many years before your surgery?
Probably a decade.
And then what type of medical management did you offer the patient before you took her to the operating room? I know I do see some things here in your case, but can you give me some other managements that were offered and attempted?
Sure. So this patient was actually referred to me by a general OBGYN, and the general OBGYN had previously tried combined oral contraceptive pills. And when she presented to me, she was on the she had a levonorgestrel IUD.
Which specific progestin IUD did she have?
The Mirena.
And how did you counsel the patient in regards to a BSO?
I counseled the patient that for treatment of her pelvic pain, I recommended a total hysterectomy with bilateral salpingectomy. However, the patient, we did discuss the removal of the ovaries, and in that if we left the ovaries, there is a potential risk of reoperation to remove the ovaries due to persistent pelvic pain. And if she did have endometriosis, the risk of recurrence for endometriosis is higher.
And how did you counsel her in regards to the negative effects of doing a BSO at the age of 50?
I discussed with the patient the risks of early or surgical menopause. So symptoms, vasomotor symptoms, mood changes. I discuss other risks, including risk of bone loss, changes in mental health, and the risk of early all-cause mortality.
And when is it usually recommended to undergo a BSO?
Typically, the recommendation is after the age of 65. You can consider removing both ovaries.
How did you discuss hormone replacement with the patient?
Prior to deciding removal of both ovaries, I discuss options for hormone replacement therapy, such as estrogen patches.
Why estrogen patches?
Estrogen patches, I'm just more comfortable using them, but I mean, there are other formulations of estrogen hormone replacement,
Such as
oral. There's also spray, the Eva Mist.
And what's ACOG stance? Which mode of administration do they feel is more optimal?
I actually don't know that. I know that it is whatever the patient feels comfortable with. Technically, if you provide oral estrogen replacement, it has a higher risk of VTE as compared to the patch.
Why is that?
I think it's because of I think it passes the first pass metabolism, and so it has a higher rate, higher concentration in the body.
The first pass of what?
Metabolism in the liver.
Metabolism in the liver? Okay. But that's not the reason that you offer transdermal administration. It's because you just feel more comfortable doing it.
I do feel more comfortable doing the patch, but I do discuss the other options depending on what the patient feels more comfortable with in terms of modality. However, I do tell them about that increased risk of VTE with oral.
So did this patient, was she started on HRT or ERT?
Yes, I transferred her care back to her general OBGYN, and I recommended initiation of estrogen hormone replacement therapy.
Could you have done this case as a TVH?
TVH. I don't think so.
Why?
On examination, she had poor uterine descensus. And because of her primary complaint of pelvic pain, it was necessary to perform laparoscopy in order to evaluate for sources of pelvic pain.
Did you do any procedure in order to suspend the vaginal vault?
Yes, we did a uterosacral ligament suspension.
Could you explain to me how you do that?
You grab the uterosacral ligaments after removal of the uterus and attach them to the apices of the vaginal cuff with closure of the colpotomy.
So what's the difference between a uterosacral suspension versus a McCall?
A McCall's coldoplasty is as far as I'm aware. I'm not sure. I think it's performed vaginally, and you grab the posterior cuff and attach it to the uterosacral ligaments, and then close the cuff.
You attach what to the uterosacral? Say that again, I'm sorry.
The posterior cuff.
So you did your uterosacral ligament suspension laparoscopically.
Correct.
Could you do a macaw laparoscopically?
I've never done that.
Do anybody that has? Do you think it's feasible?
Do I think it's feasible to do a McColl's colpoplasty laparoscopically?
Yeah.
Probably. You could probably just grab the posterior cuff and attach it to the uterosacrals.
So in regards to her endometriosis, what stage of endometriosis did she have?
She had stage 1 endometriosis.
Can you go through the different stages for me?
Oh man, that's tough. So there's different, so this is based on ASRM staging. So stage 1 endometriosis is typically small lesions and thin filmy adhesions.
Okay, and then what are the other stages?
The other stages are stage 2, 3, and 4. And as you progress along, the lesions get larger and deeper. And stage 4 is typically, commonly, you have obliteration of the posterior cul-de-sac.
And then do you know if this patient improved after her surgery?
Her pain did not improve after her surgery.
So she's still dependent on her opioids. She has no ovaries.
Correct. And I discussed this with the patient prior to surgery, that I did not believe that her pain, I was not confident that her pain would improve and that she may still experience persistent pain despite removal of the uterus and endometriosis.
So to your knowledge, she's not happy after her procedure?
I'm sorry?
To your knowledge, she's not happy after her procedure?
I think she has been ridden of one aspect of her pain, but I think she has multiple etiologies of her pain that she needs addressed.
Such as?
So she has gastrointestinal symptoms that I recommended she see gastroenterology for. She also has chronic back pain, which can lead to pelvic floor dysfunction.
So would it have been more prudent to have had those evaluations done before you took her to the operating room?
I did recommend doing that but the patient had opted to pursue gynecologic management first.
Okay, let's stop there. So what do you think?
That was hard.
Not that I know the answers to any of the things, because they'll ask you questions of things that they may not know the answer to. They just want to know
oh,
your
good,
thought
because I
process.
was like,
But I gotta be honest, if you have your endometriosis, which we all do, I would know my staging. And I thought it was really
Okay.
good how you brought up the group that it's based off of, and I thought that was nice. But you can
Do I
easily
have to
say
know?
I know. Mhm. Say again?
Do I have to know, like, because it's all based on numbers?
What do you mean?
You know,
I'm
like
sorry.
different points. It's based on different points.
Yeah, but that, you know how they have that little worksheet? I don't know if they still use the
Yeah.
worksheet. Yeah, so you could say, to my understanding, it's this, this, and this. You could easily
Okay.
say, I can't tell you the difference between the second and the third, but I know for sure the fourth is, very extensive endometriosis, and they'll give you a partial credit for that instead of saying, I really don't know.
Oh, okay.
You know what I'm saying?
Good.
Um,
Yeah.
I think, because you're a MIGS, and I'm assuming, see, they're not going to see your other lists. They're only going to see this list. The GYN
Okay.
examiners will only see your GYN list. So they
Okay.
don't know how, this could be a regular generalist that does a lot of laparoscopy.
Gotcha.
Do you understand what I'm saying? So
So
then
they won't ask
they
me what I do.
sometimes they may say,
Oh, okay.
not, I was never asked that, but they can say, tell me a little bit about your practice.
Mm-hmm.
And then you could say, I'm a MIGS trained, blah, 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 blah.
Okay.
The thing is, you have a lot of cases, number one, number two, a lot of BSOs.
Yeah.
So be able to defend why a BSO was done in every patient. So they could have really, reamed you in the sense like, oh, she didn't get any better, and they'll pepper you. She still didn't get any better. So why'd you do this? Did you do the best service for this patient? Da, da, da. They'll do stuff
Yeah.
like that to see how much you'll, get nervous or get like heated in regards to them saying that you did something wrong with the patient. And you always can,
Okay.
give it back to the patient that, well, this, I was extensively counseled my patient, and this is what she desired. She knew that after the surgery, she could still have the same amount of pain, still require the same, pain medication, blah, 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 blah. So in essence, you
Okay.
have to defend. And, and I figured you were going to say the reason I didn't do the vaginal hysterectomy was because, I wanted to see what was the cause of her pelvic pain, which you did, and she didn't have
Okay.
descensus. So you got to have a reasoning why you did it. I know you're MIGS, but
Yeah.
you have to defend why, because they always want everything vaginal,
Right. Right. Okay.
right? So then, well, in this case, she had the pelvic pain, da 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 da, da. And that's why they include and they want the weight of the uterus, because they can just immediately say, well, it was only a 39-gram uterus.
I
Okay,
know. Yeah.
so, of course, she had never been pregnant before, and so on and so forth.
Uh-huh.
What else? What else? What else? Questions of other things. We could have gone into what are contraindications to IUD use. So,
Okay.
even though that's not the focus of your case, they could take it
Mm-hmm.
wherever they want. They could have asked you stuff about her insulin. They could have done a
Yeah.
lot of different
Should I
things.
still keep that? Like I feel like the insulin dependent diabetes and the hypertension.
It's tough because who examines your GYN? It's oncology and and urogynecologist. So how much is an oncologist or urogyn going to care about the diabetes? An MFM would care more. So I
Okay.
don't know, but it could be avenues of questioning. So anything that you have here on your list is fair game.
Okay.
End of story. I don't know how else to explain it.
Yeah.
Anything and everything's fair game. So I can see them
Um,
looking through your list and say, well, you do a lot of BSOs, da 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 da. Da. So be
yeah.
prepared to defend. What you have to do is defend why you did what you did.
Okay.
Okay, you're going to say, I'm sorry.
Um, what was the answer for the McCall's and the uterosacral ligament suspension?
I think you could do both. I mean, McCall's usually done vaginal, but you could do a uterosacral ligament suspension vaginally as well.
Okay.
And the difference between the two is with the McCall, you actually plicate the uterosacrals in the midline because you tie them
Gotcha.
together, which you do not do that with the uterosacrals.
Gotcha.
Ligament suspension usually don't. So it's more anatomically correct, supposedly. But if you did that, I would definitely have included it in my list as my treatment, as one of my treatments.
Okay.
Because because a urogynecologist, I mean, they're like, man, I'm a urogynecologist. Nobody suspends the cuff anymore, or I'll have future business, one or the other.
Yeah.
But yeah, that's the difference between the two. And there's
Okay.
a lot of older procedures, the Moskowitz, the Halban, where like they close up spaces in order to prevent enteroseals and prevent
Oh,
the valve prolapse. And then of course when you have this is for prevention, not treatment. For treatment,
Yes.
then you have your sacrospinous fixation and your sacrocolpopexy, which, you know, you may not do, but I could see questions being asked in general.
Oh, wow. Okay.
I could see it. I could see it. Yeah. Because you have a urogyne examining you. It's possible. I never got asked that.
Gotcha.
But you know, in essence, everything's fair game.
Are you saying that it's most common to have a subspecialist or a gyne rather than a general OBGYN asking you
To
gyne
my
questions?
understanding, OB is tested by MFMs only. Your GYN is the oncologist and urogyne, and office is REI and very seasoned generalists. That's what I've always heard. I don't know if that's true or not. This is what we're talking about here is all assumptions. We assume
Sure.
this is what they do because everything's very closed door. I mean, a lot of the examiners do not discuss ever, you know, the process of the exam, how it's scored or anything like that. There's
Okay.
theories that everybody has. Like one theory is you can't do mediocre in all three lists. You must excel in one list in order to pass and do mediocre in the other two. You can't do half, you know, do a mediocre job on all three cases, you will fail, supposedly. True or false? I
Okay.
don't know because nobody discusses that.
Yeah.
Yeah.
Okay.
Other
Awesome.
questions?
No, thank you. That was really
Yeah, but next
useful.
time you should do the OB.
OB?
Yeah. And the thing is, I know we're here to try and get you to get comfortable and all that, but to be honest with you, they're just going to ask you questions. They're not going to give you any feedback. And I
Mm-hmm.
know, and I try not to do it. We may
Mm-hmm.
say, well, what do you think about this? They're not going to tell you that. They're
Mm-hmm.
not going to try and tease out any answers from you.
Mm-hmm.
I know nobody did that to me.
Mm-hmm.
It's like, you know what you know, and hopefully it's good enough. And I know you know, this is, you know, the first week of August. So there's plenty of time to get better and better and better. So the key here is to keep practicing and, you know, and I know you don't want to get embarrassed. And I'm talking about to everybody that's on the call. You don't want to get embarrassed and say something wrong and it'll be there for all posterity. But it's better to mess up now than in the exam because that's more egg on your face, so to speak.
Mm-hmm.
Am I making sense?
Yeah.
All righty, other questions? You're good?
Yeah.
All right, very good. Well,
Thank
good
you.
job. Thank you so much for participating. Do I have, I'm going to mute you now. Very good. Do I have anybody else who wants to sit in the hot seat? And if you don't have your list, it's okay. We can just pick somebody else's list. You just pick a topic that you're interested in or a case or a list. I don't see anybody raising their hands. Okay. Aviv, I'm heading over in your direction. It says you're self-muted. There you
Hi,
go. Can you hear me now? Hey, how we doing?
good, thank you.
Okay, what would you be interested in doing?
Um, Anything.
Are you a generalist?
I'm a generalist, yes.
Generalist, so it really doesn't matter. Okay. And again, kudos for stepping up to the plate. Because I'm going to tell you right now, in like October, like right now on this call, we have 7 people. So there's, you know, if you want to participate, there's plenty of, you know, you're able to do that. In October, there's going to be like 70 people on the call. So you want to participate at that point, you're probably not going to get chosen. You know what I'm saying?
Yeah.
So it behooves you, and you've paid good money, so it behooves you. That's the way I see it.
Yeah.
I'm just going to make this a little bit bigger if we can. So case number 15. What is the Rotterdam criteria?
Okay, so the Rotterdam criteria are set to diagnose PCOS. And in order to diagnose PCOS, we need to have at least two of, we have ultrasound findings, which I'll go through, and we have adrenergic symptoms such as hirsutism, acne, metabolic syndrome, oligomenorrhea. As per the ultrasound findings, we're looking at polycystic ovary on the ultrasound, which is at least 12 follicles, I believe, for ovary, or 9, I'm sorry. And the volume is also can be calculated, and if it exceeds 12, I believe, then that will hit the criteria for PCOS.
So you brought up metabolic syndrome. What's metabolic syndrome?
So metabolic syndrome is has criteria. So that can be 2 or more of a waist circumference of about 85.
85 what?
Centimeters. I believe hypertension, BMI of about 35.
So what would be the blood pressure?
The blood pressure would be above 130 systolic or 80 diastolic. So that's 3, I think I gave. And another criteria would be, I said, lipidemia. There should be 5. So BMI, hypertension, waist circumference, lipidemia, and the fifth one doesn't come into my mind. I think there's 5.
And how many have to be present to meet criteria?
I believe it's 2 or more.
Can you discuss the growth phase of hair for me?
Again, the growth, what?
The growth, the phases of hair growth.
Oh, sure. So the hair has, I believe, 4 phases, which is in relation to its growth. There is the first stage when the follicle, the hair come out of the follicle, and then there's the elongation of the hair. Then it goes into a period when it just stay without any changes, and then it goes into a phase that we see that the hair falls. I think there's some kind of apoptosis that release the hair from the follicle. I'm not sure about the specific titles or the names of each phase.
And what is the mechanism of action of the oral contraceptive pills in regards to hirsutism?
So some of the progesterones will have partial anti-androgenergic characteristics, and they will affect the growth of the hairs. So they will have I think it's, I don't know if it weakens the hairs or just doesn't encourage any new growth. But the anti-androgenergic effect of the progesterone is the part that use in that sense from OCPs.
So are there any specific OCP brands that work better with hirsutism than others?
Yes, we specifically talk about progesterones from the 4th generation, as some will divide the groups. So drospirenone will have this kind of effect, and that will be in the brand name Yaz or Yasmin. And for people who wants to achieve this kind of effect, I would usually tend to prescribe OCP from that group.
So let's say she tried the birth control pill and she's not happy with the results. What other options are available for treatment of her hirsutism?
So yeah, so OCP will be the first line. Of course, if the patient is not planning to get pregnant, so any in terms of fertility, if she's good with the contraceptive effect, that will be my first line. Then after that, we can use other agents such as spironolactone that can also treat hirsutism with the counseling that it will cause more of diuresing, maybe effect of dry mouth. Other than that, there are the topical treatment that the patient can be counseled about, which is hair removal with plication, lasers, things like that.
And I'm sorry, is there another medication you can offer her for treatment of the hirsutism?
Yes, there are other medication. There is one more group. I cannot think about it right now. But yeah, there are other options.
All right, well, let's stop there. How do you feel?
I felt that I could not give like the full answer that I want to give. Like I had something, but not the full story, so it doesn't feel good.
Because you have all this knowledge, but you can't formulate it into words. So that's why practicing is so important.
Yeah.
That's the only thing I could recommend. You could read, you have to read, don't get me wrong. You got to have the knowledge base. But then on top of that, you have to have get the skills for the verbalization required to do the
Right.
oral exam. Okay. So the Rotterdam criteria, you said, I think at one point BMI, and that's not really in the Rotterdam criteria. So you need 2 of 3. It's either oligomenorrhea, hyperandrogenism, and polycystic ovaries, which is greater than 12 cysts, 2 to 9 millimeters in size, or a ovarian volume of greater than 10 cc's.
Okay.
You said 12.
Yeah.
Metabolic syndrome, you need 3 of the following 5, and BMI is not one of them. It's a blood pressure of 130/85, a fasting glucose of greater than 100, a waist circumference of 35 inches. I don't know what that is in centimeters.
Yeah,
So my apologies.
Yeah.
Triglycerides of greater than 150 and an HDL of less than 50.
Okay, yeah.
Okay.
Mm-hmm.
So
Yeah.
growth phases of hair. I thought you did a good job for not knowing the names of them, but I thought you did a good job in like the overview. And there's nothing wrong with that. You're gonna get partial credit for that, which is
Okay.
better than saying I don't know.
Yeah.
Right? So you have anagen, which is the primary growth phase, and it's the majority of time hair spans. You have catagen, the hair follicle involutes at that point, and then telegen, that's the resting phase that lasts several months. And then the hair sheds at that point, or in that stage. Now, the mechanism, to my understanding, the mechanism of action of OCPs in regards to hirsutism is it increases the sex hormone binding globulin, thus decreasing the free testosterone.
Oh, okay.
But yeah, there are some, birth control pill brands that are preferred over others. That's correct. But to my understanding, the main reason is that the increase in the sex hormone binding globulin.
Okay.
Okay. Now, another medication that you can give for hirsutism, and you did fine by saying the laser and the cream and this, that, and the other, is spirolactone. Spirolactone.
Okay.
Okay. So, because usually first line is the oral contraceptive pill, and if that doesn't work, then you go to spirolactone and you give it 6 months to see. That's when you get your most maximum benefit.
6 months. Okay.
Yeah. Okay. Other questions? Good job.
No, thank you.
Again, it's the beginning of April. Excuse me, August. I wish it was April. It's the beginning of August. So the only way to get better is by doing it.
Yeah, I agree. I think there's nothing better than just putting you on the spot and just.
Yeah, who likes being on the spot? But you're paying good money, get your money's worth. Do you have any other questions about anything in regards to, the submission of the list, anything in general about the exam?
Yeah, I had a question about dosages. Like there are so many medications. So I was wondering, like the medications that I don't use routinely, I find it hard to remember the dosage.
Right, and I think you're okay. If you have a specific medication on your list, I would know its mechanism of action, its dosing. If it's not something like you don't have spirolactone on your list, right? But they
Right.
can ask you, what other agent can you use? And they can ask you, what's its mechanism of action? What's its dose? And if you're getting to that point, they're going in the weeds, you're done well in that particular case or
Okay.
that set of questions. When, because I was asked in one of my structured cases, it wasn't on the slide, I knew when I read the vignette that it was about pertussis, and the question I got asked, which was the last one, it was not on the slide, was how do you culture pertussis in the lab? I was asked that in my exam.
Oh my God.
So I mean, if they're asking you something like that, I mean, seriously, am I supposed to know that? You've done well in that section.
Okay. Yeah.
Because that's, you shouldn't know that. That's
Yeah.
not gonna make or break being an OBGYN.
Yeah. Okay.
And she knew it. And she knew it. She just wanted to show, like, I got you. I'm like, yeah, you got me. That's cool. Just pass me. And that you have to be very, what's the word I'm looking for? You have to be very, you have to be sure of what you do.
Yeah.
But you also have to not fight with the examiner because they will try and do that. Am I making sense?
Yeah.
You have to find a happy medium. And you know how sometimes you get in a heated argument with somebody?
Yeah.
And in the end, you got to let them win. You can't win because right there you're gonna fail. Okay, so you got to let them win. And at some point, you could say, well, unfortunately, I disagree. This is the way I manage the patient. You come up with something nice to say. Instead of saying, I think you're completely wrong, you're crazy. You're like, that might be so, but I feel that this was the proper management for this patient. And luckily, she had a good outcome, or however you want to word it. But in the end, they are the smartest people in the room.
Yeah. Okay.
You gotta just accept that and give it to them, for lack of a better word. Okay. Other questions? So I think if they're asking you questions on dosing, on a medicine that's not even on your list, you're doing well in that particular that particular, you know, case or avenue of questioning, because, you know, they're going to try and get you into that rabbit hole and see if you can get yourself out of it.
Yeah.
Okay. All right. Other questions?
No, I don't have further questions right now.
Okay, well, very good job.
Thank you so much.
All right, you take care. Thank you for being on the hot seat. Do we have anybody else who wants to participate? If you do not have your case list, we can pick somebody's and just, you can tell me what topic. I see there's a hand up here. So Miss Tiffany, I'm heading over there. It says you're self-muted. Now your hand disappeared. Are you interested in being on the hot seat? It says you're self-muted. Oh,
Okay.
Can you hear me now?
Yes.
Do you have a question?
No, I was gonna volunteer for the hot seat.
Sweetness. Okay, so what case list are you looking for? OB/GYN?
Let's do OB.
Let's do OB, and I'm just picking the last one here on the list. So we're going to use Dr. Delaras. Hopefully I'm pronouncing her name wrong. Right. Oh, wait. It says, There we go. I'm just looking.
Sure.
So let's do case 11. So what are contraindications to a VBAC?
Contraindications to a VBAC would include typical contraindications to a normal vaginal delivery, such as placenta previa, breech presentation. Those are the ones that I can think of right now.
So how many C-sections can you have and attempt a VBAC?
Per ACOG guidelines, you can have had 2 low horizontal incisions and still be a candidate for a VBAC.
So what do you mean by low horizontal?
A horizontal incision on the uterus, you have a higher risk of uterine rupture if there's a classical or vertical incision, and so those patients are not candidate for VBACs.
So what about a low vertical?
I would err on the side of recommending for a repeat C-section with that patient.
So what is the risk of rupture with a classical C-section?
Typically with horizontal incisions, it's less than 1%. I believe it's around 2% or higher with the vertical incision.
So you're telling me that you have a less than 1% chance of a uterine rupture with a low segment transverse, but it only goes up 1 percentage point to 2% with a classical.
I'm
Is that what
not
you're telling me?
100% sure about the rate of uterine rupture with a vertical incision.
So how do you counsel your patients in regards to a VBAC or a TOLAC?
So I talk to them in terms of maternal and fetal outcomes. There's better healing for mom and baby with a successful vaginal delivery. For mom, in terms of lower risk of infection, bleeding, potential injury to surrounding organs. For babies, they tend to do better respiratory-wise. In terms of risk associated with a TOLAC, they need to understand that there's a less than 1% risk of uterine rupture, but it can be associated with significant consequences if we're unable to get mom and baby back for a C-section, or in a timely manner. There's always a risk of bleeding to mom and baby, lack of oxygen supply to baby, leading in brain injury, brain damage, and if there's enough blood loss, potential risk of maternal and fetal death. At the same time, the risk of, in terms of like successful outcomes, most successful outcome is obviously a successful VBAC. Second best outcome would be a planned cesarean delivery. Least successful outcome is essentially a failed TOLAC and then eventual C-section.
So what are signs of uterine rupture?
It can be vague to identify, but usually the first sign is the fetal heart tracing is non-reassuring. You may also see an abruption pattern with like contractions every minute on the fetal heart or on the TOCO monitor.
Are you sure about that?
Yes. It's not, for example, the abruption pattern may not always be present, but those are potential signs. I guess another sign would be if the patient is having pain out of proportion, or out of proportion pain in terms of what you would expect in labor, would be another finding that would increase my concern for uterine rupture.
Anything else?
Those are the main ones.
So let's say you have a patient who has an arrest of descent.
Mm-hmm.
How would you counsel her in regards to a TOLAC?
Oh, a patient with a history of arrest of descent. So there is a VBAC calculator that can be used, and it incorporates maternal factors such as age, BMI, history of hypertension, prior vaginal deliveries, and indications for the prior C-sections such as arrest of descent. Having such a history having such a history of arrest of descent decreases your risk of a future successful vaginal delivery after a C-section.
So do you know what percent success rate a arrest of descent would have for a successful VBAC?
I would expect that with a history of arrest of descent, it would decrease the success rate, but I'm not sure of the percentage.
So let's say you have a patient who comes in 10 years ago, she had an arrest of descent. This is her second pregnancy with a new love of her life, and she's adamant because he wants her to have a natural delivery, even though she had a C-section for arrest of descent.
Mm-hmm.
What would you tell this patient?
I would basically counsel her on the things that we previously discussed, and if she decides that she would still like to try for a TOLAC, we can certainly try.
But what would you would you tell her what type of success she would have?
In counseling, without having the calculator in front of me, and in counseling patients in the past, I have had patients with that history of arrest of descent, and they still had at least around a 50% success rate.
Did they have anything else in the information plugged into the calculator that improved their chances? In your recollection?
Not to my recollection, no.
So how is a positive antibody screen managed? Can you give me a little bit background, what you know?
In terms of antibody screening, certainly a patient who has had a blood transfusion in the past may be at risk of having a positive antibody screen. If I was managing a patient during her prenatal course and she had a positive antibody screen, we should identify what type of antibody she has. Certain antibodies are more concerning in the pregnancy, like Duffy antibody. When a patient has a positive antibody screen, I typically also get the titer levels and continue monitoring those levels. The patient would also need antenatal surveillance.
Is there something that you could do at the beginning of the pregnancy to see if you needed to go down that route?
Typically with the prenatal labs that I order at the beginning of the pregnancy, it includes a type-in screen.
So let's say, what titers do you get concerned about?
Duffy is the concerning one because at higher levels, the baby can potentially die because of that.
Yeah, but what numbers are you looking for in your titers? Like at what point you say, I'm concerned, I need to do something?
1 to 8.
For the Duffy, what about Kel?
I think that might be 1 to 8 as well.
And when would you start initiating antenatal testing?
So in terms of titers, I believe they should be repeated on a monthly basis. Typical antenatal surveillance usually involves NSTs and routine growth ultrasounds. And so with the NSTs, I would typically start at 32 weeks. Growth ultrasounds usually every 4 weeks, past 28 weeks along, or starting at 28 weeks along.
And at any point, would you start doing more invasive testing?
If the titers were high, yes.
What do you mean by high?
Greater than the 1 to 8 threshold.
So let's say you have that, what would you do?
I believe in certain instances, if the titers are elevated, there's a chance of basically baby having fetal anemia. And if they're elevated enough, there's a possibility that the baby may need an intrauterine blood transfusion.
So how would you follow the fetus in order to assess if that's a requirement?
Typically, you start with measuring mom's antibodies. I know there are more.
So let's say her antibody or her titers are elevated. What would you do next?
Yeah. I can't even recall the name of the test. I can't recall the name of the test at this time.
All right, so let's stop there. It's a topic that I know I don't like to talk about.
I feel like
Which
I was
nothing. Look how you jumped from VBAC to ISO immunization. Nice. And they're gonna do that.
It's pulling way back to the residency days and seeing what I could remember. So.
But I could see that being a structured case. I could see it.
Yeah, I could see that.
A couple years ago, the structured case was McCune Albright. Hello. Hello. What do you know about McCune Albright? I know nothing. I would have been sitting there going, what? So contraindications to a VBAC is any contraindication to a vaginal delivery. Please do not forget about the number of C-sections. Because you didn't bring that up. And if she's had a prior classical, right? That's the point of getting the op report. If I'm not mistaken, a classical has up to a 10% chance of rupture. That's why you don't let them TOLAC. You can, you have a 90% chance of success, you know, but that's why they feel 10% is a little too high versus the LST being less than 0.5%.
Gotcha.
And you kept calling it horizontal incision. Is that really the
Mhm.
best terminology?
No.
No, so it's low segment transverse.
Okay.
That being said, if I'm not mistaken, and I'm not saying I support this, I am not an MFM, they say if you have a low vertical on the lower uterine segment, you can try and do that natural.
Okay.
You know, do a TOLAC, which I don't feel comfortable, but I just double check me that.
Okay.
See, but you started saying things, and then I started getting questions from it. I never would have thought of asking anybody if you had a low vertical incision, but the way you said horizontal, it
Mhm.
triggered that. So a lot of times the way you word things can trigger the examiner to take you somewhere.
Okay.
Okay? So that's why the practicing, because when you first start doing this, it's like you have diarrhea of the mouth. You're just talking about everything, whatever comes in your mind. You're like, well, I don't know. And then that's how you start shooting yourself in the foot.
Okay.
So with practice, you'll be able to tailor what you say, be concise, precise, and not, do, superfluous information, which could like really lead you into that rabbit hole.
Mhm.
Signs of uterine rupture: vaginal bleeding, loss of station, of course, the non-reassuring fetal heart rate, the lower abdominal pain that's in proportional. I did not know, I'm going to be honest with you, that you would have an abruption type of TOCO.
I would
Um,
potentially double
because
check that. That was just
because you lost the content inside the uterus is out, so
okay.
you don't have a confined space. So I don't think you'll even pick up any contractions at that point. I mean, unless the
Okay.
patient's like pushing on her stomach, like she, how some patients bear down and they can make it look like they're having contractions because they want to stay and they're not. I don't know if I'm making sense.
Okay.
But to my understanding, I mean, if she had an IUPC, it'll be all gone. You know what I'm saying? Because the confined space, you're not going to be able to measure anything.
Gotcha.
So isoimmunization is one of my favorite topics. Not. First thing, you should always you go high level to more kind of like the broad to more focused. So the first thing to ask is, does this particular antibody lead to hemolytic disease of the newborn? If it doesn't, you're done. So what, Lewis, right? Lewis lives, Duffy dies, Kell kills, right? So if it was Lewis, that's it, you're done. You don't have to go any further.
Okay.
Then you should determine the paternal antigen. Okay? If positive or unknown, then you'd have to do all the, who the daddy is. The patient may not know, then you're stuck doing all this stuff. However, according to Up to Date, you could do fetal antigen status by cell-free DNA, even though when I talk to MFMs, they don't offer that. But according to Up to Date, there's that capability of assessing the fetal antigen status. So if the fetus doesn't have it, then you don't have to worry about it, so to speak, so on and so forth. So then if the fetus antigen is positive and you have the risk of the hemolytic disease of the newborn, then you perform serial maternal antibody titers every 2 to 4 weeks.
Okay.
Now, usually the critical titer is anything greater than or equal to 16, 1 in 16.
Okay.
That's for non-Kell. Kell is the different one. So Kell, anything greater than or equal to 4.
Okay.
And then what do? You initiate Dopplers. Okay, you forgot Dopplers. In the old days, they used to do amnios and stuff like that. And they would check, they do something called a Lilly curve, where they would see how green tinged the fluid was, and there was curves for that. And then depending on how it looked, it was a greater chance that the baby was anemic.
Okay.
Don't ask me, I never saw it, but that's like very, very, what's the word I'm looking for? Historical, for lack of a better word. So then you do Dopplers starting at 24 weeks, every week to 2 weeks. And then if your MCA has greater than or equal to 1.5 MOMs, then you begin antenatal testing at 32 weeks and deliver at 37 to 38 weeks. And if you're in, if you have to do any assessment of for fetal anemia, any hematocrit less than 30 or an estimated gestational age of less than 35, you perform the transfusion. And then if you're greater than 35 weeks, you just deliver. So that's just a quick overview of ISO immunization. Not that I'm an expert at it.
Gotcha.
Questions?
I tried to give some information, I feel like, when I wasn't 100% sure of the answers, but I was wondering, was I just shooting myself in the foot?
You know, I think that's a hard one to tell candidates about, it, because we all know something about many things, right?
Mm-hmm.
So you can always preface by saying, you know, I'm not 100% sure, but if my memory serves me correctly, I believe this and this and this and this. So you're not
Okay.
outwardly saying, yes, I know 100%, but you also, you know something, but you don't want to, you know, it's so easy to say, I don't know, and get 0 points.
Mm-hmm.
You know what I'm saying?
Yeah.
So one of the faculty, Dr. Foley, always brings up like the cancer staging.
Mm-hmm.
You know, what's the, you know, tell me, discuss with me, you know, the staging of endometrial cancer. Well, the first thing you're going to say is, unless you're an oncologist, like, I don't know. You're going to say, I don't know. Well, then you just lost points, right? So
Mm-hmm.
you could say very easily, it's like, you know, I'm not 100% sure, to be honest with you, the specific staging of endometrial cancer. However, I do know stage 1 is confined to the uterus and stage 4 has distant metastasis. Well, there you go. That's partial credit versus I don't know.
Mm-hmm.
So I think with time and practice, you'll come up with that rhythm in your mind on how to answer something. Or you could say in your mind, because when you're out of, when, you know, because you've never done this type of exam, if you're out of practice, what I call out of practice because you don't do it, you're thinking in your mind, what do I say? I don't know. Da, da, da. But when you've been practicing, you're going to be very quick-witted in your head and you'll be able to verbalize it.
Okay.
Instead of sitting there and saying, ah, 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 ah. And you can clearly see, you know, because I do mock orals, and then when the season progresses with the webinars, in the beginning, people are like, ah, ah, thinking, while those that have been practicing and have been doing the webinars and mock orals and all that stuff and practicing, you start seeing that there's less ah, ah, and they know more and more and more because they're able to verbalize. Not that you know more, it's that you're able to show what you know, verbalizing it. Does that make sense?
Mm-hmm. Yeah.
And the only way to do that is with practice.
Okay.
You know, I wish there was another way, you know, some special pixie dust or something, but no. Other questions? But good job. I mean, ISO immunization, that's not easy. That would have been like,
Thanks.
whoops, what? So you did a good job. Very good.
Thanks.
Any other questions?
You know, as I'm going over my case list, I guess in terms of like when talking about like non-reassuring fetal heart tones and like indicating that it's category 2 tracing or like taking someone back for a C-section, is it sufficient to just say non-reassuring fetal heart tones, or should I like say like there's multiple or like
Include the category because that is the proper nomenclature. Non-reassuring, that was back many, many moons ago when we didn't have, now it's a category 1, 2, or 3 tracing. And they could say, what's a category 2? What's a category 3? They want those answers. Non-reassuring is slang. I call it slang. That is not the appropriate terminology.
Gotcha.
So please remove anything non-reassuring. It should be your category, whatever tracing.
And so just to say category 2 tracing is sufficient, I don't need to like further quantify with like.
No, you don't. You don't. But be prepared to discuss what made that particular tracing category 2 if they ask.
Okay, gotcha. And then if you're okay with me asking another question. So I had a GYN case where she had a small, simple ovarian cyst, and like we're all taught that like you should do a cystectomy instead of a cystotomy. But I think because of in the moment, a cystotomy was done and that was that. So how do I go back and defend that?
How big was the cyst?
It was it was 3 centimeters or less. I want to say, Yeah, I think it was about 3 centimeters.
So I think that's where you have to hang your hat on. You would not do that if it was 6 centimeters,
Okay.
right?
True.
And you could say, you know, by the size of the cyst, you know, it looked very simple. It wasn't, it was less than 3 centimeters or less than 2 centimeters, whatever you want to word it. And it's not we, it's I, even though it's possible your partner did that. Um, I decided just to, you know, aspirate the fluid contents or do a cystotomy or whatever you want to call it.
Okay. All right. Cool.
Okay, so you go by your size then at that point, because you're not going to do that at 6.
No. Right.
So, right.
Awesome.
Right. Other questions?
Well, since you're asking, there was another GYN case where it was a dermoid cyst and it was 6 centimeters. And, you know, the guidelines would say, you know, you just go in and remove the dermoid. However, I ended up doing an oophorectomy because there wasn't really much ovarian tissue left and there was concern for bleeding. And I had counseled the patient beforehand. Is that sufficient?
Sounds great to me. You said it.
Okay.
There was not
right.
much. I mean, there's always some ovarian tissue left. You know, there's always a possibility, and I'm sure you did it laparoscopically, right?
Yeah.
So it makes it much more. I mean, that you know, it's hard when there's that little bit of like the entire ovary is encompassed by the cyst. It's very hard to find any proper tissue to leave behind. I mean, it's much easier if you had opened her up. You know what I'm saying? But then you say I counseled her extensively in regards to this. There was really no normal ovarian tissue or no, you know, ovarian parenchyma that I saw. So I thought it'd be more, you know, it'd be prudent to remove the ovary in its entirety. How old was she?
36.
36.
And she had
She wasn't,
one
it wasn't like she was 20. And she had several kids, you said?
child. One.
One, okay. So I think the way you worded it sounded fine to me. I mean, they could be jerks about it, but you defended it. The key here is to defend what you did.
Okay.
Okay.
All right. Sounds good.
Right.
Thank you.
Anything else?
Nope, that's all I've got.
All right. Very good. Well, thank you for being on the hot seat. Great job.
Thanks.
So we're past time now. I'm just trying to see if anybody has any questions, and you know, however long it takes is however long it takes. Oh, I see Aviv has a question. I'm going to you here. You have a question, my friend?
No, I don't know why it came up.
Oh, okay, no worries.
Sorry.
All righty. No, yeah, no worries. So I'm just going to go down the list, guys. Does anybody have any questions about anything? Doesn't have to be anything that we discussed today. It could be just something about your case list, you know, the exam in general. I'm just going down the line here, guys. Please raise your hand if you have any questions. So I don't see anybody has any questions. So I really appreciate the individuals who decided to participate. I think, you know, it's hard to be on the hot seat, but I think you start learning how to think on your feet and verbalizing things. And the only way to do it is by practicing it. And you paid good money for this, so use your money wisely. I know it's not cool to make a mistake and you're on a tape forever. Like I said, I'm sure there's tapes of me messing up left and right many moons ago that Exam Pro has. But you know, I sit here and say I passed. So there you go. So the key here is to say you passed. Regardless how you got there, you want to pass. So I'm just going to ask one more time if anybody has any questions before we end the call tonight. Okay, I don't see anybody have any questions. I know tomorrow there is a structured case webinar because tomorrow is Wednesday. So that's where they give you questions as the first half of the first 30 minutes of your exam or each section. But at this point, I'm going to wish everybody a good night and good luck studying and finishing up all your case lists because you know the deadline's fast approaching. Have a good night, guys. Thank you so much. Thanks for everybody who participated. You did a great job. Have a good night. Bye-bye.